Good afternoon, and welcome to today's Ensuring Person-Centered Care for Children with Autism in North Carolina Medicaid webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreter for today are Crystal Bradley and Jeannie Moorfield. Closed captioning options are available. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics includes background context, proposed updates to the research-based behavioral health treatment clinical coverage policy for August 2026, statutory changes under the House Bill 696, and a look ahead at additional updates under consideration. At this time, I would like to turn it over to Angela Smith, Chief Clinical Officer of North Carolina Medicaid.
Good morning. Thank you all for making time to meet with us. My name is Angela Smith, and I serve as the Chief Clinical Officer for North Carolina Medicaid. You'll be hearing today from LaCosta Parker, who serves as our IDD and TBI Program Manager for North Carolina Medicaid. We also have Dr. Keith McCoy on the call as well to help support the Q&A portion of the call. Dr. McCoy is our Chief Medical Officer for DMH DDSUS and the Associate Medical Director for North Carolina Medicaid. As you all know, we're working hard to get our arms around the recent growth of research behavioral health treatment, or RB BHT services. This is a national trend that we're also seeing in North Carolina. Our main lever to manage utilization of clinical services is, of course, our clinical coverage policy, specifically Policy 8F for research behavioral health treatment. Given the urgency to do our best to ensure children who need access to these services have appropriate access, and to maintain the viability of the program, we've expedited the promulgation process for Clinical Coverage Policy 8F, all of which LaCosta is going to tell you more about. The policy has gone through the Physicians Advisory Group, or PAG, on April 30th, and we plan to have it posted for public comment within the next week, with promulgation in August. We appreciate the collaboration with our community partners. Thought leaders in this space have really been incredible partners, teaming with us to help inform the changes to Clinical Coverage Policy 8F. Moving a policy along this fast takes incredible focus, attention to detail, and teamwork to align all the moving parts, always with the goal of ensuring the people of North Carolina have access to the care they need when they need it. So again, just a special thank you for carving some time out of your day to learn more about the upcoming policy changes in this space. With that, I will turn this over to LaCosta.
Thank you, Angela. I appreciate that. So good morning, everyone. I want to begin by grounding us in the broader context. Autism prevalence within Medicaid has grown substantially in recent years. As many of you know, Medicaid plays a central role in ensuring access to autism services, including applied behavioral analysis and other evidence-based supports. The rapid growth has created both opportunities and challenges, particularly as clinical standards evolve and service needs increase. So as we move into Medicaid coverage for applied behavioral analysis, just as a reminder, CMS clarified back in 2014 that states must cover autism diagnosis and treatment under EPSDT. While ABA isn't explicitly required, all states now cover ABA for children under 21. And in North Carolina, coverage is provided through the RB BHT benefit. This benefit is essential to ensuring access to high quality care. So in North Carolina, RBBHT includes ABA and other modalities supported by credible scientific evidence. Like many states, we've seen rapid increases in utilization and spending, and at the same time, federal and state oversight, particularly from the Office of Inspector General. And this has been increasing. Individuals, families, and stakeholders should expect our continued attention to clinical quality, billing accuracy, and alignment with emerging best practice standards. So, North Carolina has experienced exponential increases in RBBHT spending in recent years and over a short period of time. When spending rises this quickly, it naturally raises questions about whether services are clinically appropriate, whether the treatment is individualized, and whether oversight structures are sufficient. These trends directly inform the policy updates that we will be discussing today. So, North Carolina is responding to RBBHT utilization and spending trends. How are we responding? To respond effectively, North Carolina DHHS partnered with families, providers, health plans, and other stakeholders to identify key drivers behind this growth. Based on that work, we are implementing two sets of updates to the RBBHT clinical coverage policy, or as some reference it, clinical coverage policy 8F in 2026. These updates are informed by the Ensuring Person-Centered Care Policy paper, which was released in 2025 and shaped by extensive public comment. The intent is to strengthen quality, align treatment with best practices, and improve consistency across the system. So the proposed research behavioral health treatment, RBBHT clinical coverage policy updates for 2026. The first set of updates, scheduled for August 2026, focuses on strengthening treatment, planning, caregiver engagement, provider standards, billing clarity, and appropriate use of telehealth. These updates are designed to better support providers in delivering quality, high quality, person centered services and to increase clarity in specific areas. On the slide that you have before you, let's discuss key drivers behind the updates to help you understand the why behind these changes. North Carolina DHHS conducted a thorough review of RBBHT claims data, provider feedback, family perspectives, and national standards. Several key drivers emerged. Those drivers were treatment isn't always aligned with evidence-based standards or sufficiently individualized. Current billing requirements lacked clarity, creating provider confusion. Telehealth sometimes being used or is sometimes being used in situations where in-person treatment is clinically necessary. RBBHT is sometimes being delivered as the primary service, even when less intensive supports may be appropriate. We've seen a major influx of new providers entering the North Carolina market. All of these findings inform the upcoming policy updates and will guide the department's ongoing collaboration with the provider community. So when we talk about key context for the changes discussed today, keep in mind that in addition to the updates to the CCP, the state is exploring additional pathways to ensure access to high quality and appropriate RBBHT services. North Carolina Medicaid is collaborating with health plans and the North Carolina Department of Justice on evaluating and strengthening existing program integrity protocols, including the monitoring plan for RB BHT services. The North Carolina legislature has passed new RB BHT legislation to address provider standards, use of telehealth, and enforce service quality standards, among other areas. Policy changes included in this presentation are subject to change based on new statutory requirements. The changes discussed today are summaries. Additional details on each of these requirements will be included in the CCP, that's the clinical coverage policy, when it is released for public comment. So let's talk about the strengthening treatment planning and service delivery standards. We are implementing new requirements to ensure that services truly reflect each child's individual needs. As many of you have shared, and our review confirms, treatment plans haven't always aligned with the national guidelines or individualized practices. These updates ensure plans are more clinically rigorous and more person-centered. So in the next slide, we'll talk about strengthening treatment and planning and service delivery standards. These policy changes include several key expectations for providers. First, treatment plans must be informed by a validated assessment tool and be updated regularly. Second, plans must include standardized elements like justification for treatment hours and whether the model is focused or comprehensive. We're also requiring a weekly service schedule that includes all Medicaid and non-Medicaid services to support better coordination and prevent duplication. Finally, observation and direction hours must fall within 10% and 20% of technician hours unless clinically justified. These standards align with national best practices and support high quality supervision. So as we continue this, as we talk about strengthening caregiver engagement requirements, one of the strongest predictors of sustained progress is caregiver involvement, to better support long-term outcomes. We're establishing minimum caregiver engagement standards. This includes embedding caregiver-focused goals into every treatment plan. Our goal is to ensure that skills generalize beyond structured sessions and that families feel equipped to support progress, at home and in the community. So as we continue to talk about strengthening caregiver engagement requirements, these new standards require at least 2 caregiver-specific measurable goals in each plan, as well as a minimum of 6 parent training sessions during each 6-month authorization period. Caregiver training must also appear in transition and titration planning. If caregiver training is limited or omitted, providers must document why. We understand there are times when participation isn't possible, so the policy allows flexibility while still ensuring accountability. So let's talk about strengthening provider standards. Another key focus area in provider qualifications. Most RB BHT service hours are delivered by technician, yet certifications have not previously been required. As the workforce grows, especially with many entrants into the North Carolina market, it's essential that providers meet consistent professional standards to ensure safe and effective care. So in the next slide, we'll continue the discussion on strengthening provider standards. diagnostic requirements is the specific focus on this slide. We also have questions from providers about who can diagnose autism for RB BHT eligibility. The updated policy clarifies this. Provisional diagnoses for children under 3 can be made by physicians, licensed psychologists, licensed psychological associates, or master's level clinicians with appropriate training. These diagnoses are valid for 6 months. Non-provisional diagnoses must be completed by physicians, licensed psychologists, or psychological associates using a validated tools like the ADOS-2, VOSA, or TeleASD PEDS. So as we continue the discussion of strengthening provider standards in this slide, to improve service quality, technicians will now be required to obtain and maintain certifications from either the BACB or the QABA. Many states have already implemented similar requirements. We are phasing this in to avoid disruption to care, and new hires will have 120 days from hire to complete certification. Our intention is to support a workforce that is both well-trained and consistent with national standards. So let's talk a little about clarifying billing requirements. Billing consistency is an area of ongoing concern for both providers and health plans. We are implementing updates that clarify allowable billing practices across RBBHT CPT codes and help standardize documentation. The goal is to reduce ambiguity and strengthen oversight, not to create unnecessary administrative burden. In the next slide, we'll continue discussing clarification of billing requirements. These updates clarify what constitutes billable activity under CPT code 97155, specifically real-time feedback and demonstration of protocols. Non-billable activities like ensuring technicians are practicing ethically or continuing their professional development. We also specify when concurrent billing is appropriate, and we clearly outline which provider types can bill each code. This level of clarity is intended to support compliance and reduce audit risk. In the next slide, we'll discuss reinforcing allowable billing under RB BHT. With utilization increasing substantially, it is critical that RB BHT services are delivered only when clinically appropriate and not used in place of less intensive supports. These billing clarifications reinforce the intent of the service and reduce inappropriate or duplicative billing. So in the next slide, we'll continue reinforcing allowable billing under RB BHT. This policy explicitly prohibits billing RB BHT for services that duplicate or supplant non-Medicaid supports, such as IDEA services. Additionally, RB BHT cannot be used for respite, custodial care, or habilitative services. Activities like naps, transportation, meals, or unstructured time also cannot be billed. These clarifications ensure that Medicaid funds are used appropriately and that treatment is clinically meaningful. In the next slide, we'll talk about establishing limits on use of telehealth. We've observed that telehealth use has nearly doubled from 2024 to 2025. While telehealth is an important tool, overuse, especially in settings requiring direct observation, can compromise quality. For that reason, we're establishing clearer limits to ensure telehealth is used only when clinically appropriate. And the next slide, we'll continue to talk about establishing these limits on the use of telehealth. Under the updated policy, telehealth will no longer be permitted for key assessment and direct service delivery codes, including 97152, 97153, and 97154. These services require in-person interaction to ensure high-quality intervention, environmental understanding, and meaningful supervision. Providers may still deliver parent training codes 97156 and 97157 via telehealth. We will also define circumstances under which 97151 may be delivered via telehealth with clinical justification. Finally, out-of-state providers, those that are more than 40 miles outside of North Carolina, will no longer be permitted to deliver RB BHT services in state. So we're going to switch gears a little bit and talk about House Bill 696, statutory changes to the RB BHT coverage. Right? Thank you. So House Bill 696, Medicaid coverage for ABA therapy. This legislation outlines specific requirements affecting supervision, telehealth, provider eligibility, prior authorization processes. One key change limits the percentage of observation and direction conducted via telehealth and places new expectation on supervision levels when paraprofessionals deliver high volumes of service hours. Another change prohibits out-of-state providers, particularly BCBAs and supervisory staff, from enrolling or delivering services in North Carolina. Finally, the bill sets more frequent reauthorization requirements for treatment plans exceeding 16 hours per week. So looking ahead, additional changes being considered or explored. Beyond the August and December clinical coverage policy updates, North Carolina DHHS is exploring additional strategies to ensure access, quality, and sustainability. These discussions are ongoing and will involve continued collaboration with community providers. In the slide before you, we'll talk about possible future policy changes. Potential future policy changes include strengthening diagnostic standards, exploring provider accreditation options, and aligning reimbursement rates with quality measures. We are also considering new requirements for whole person care planning, increasing awareness of non-RBBHT services, and addressing provider network growth. Your feedback during these processes will continue to be vital. So at this time, I want to remind you that the public comment period for the August 2026 update is coming up in May. I think we are planning by the end of this week. Again, your input is essential. The policy will be posted for 30 days. We encourage every provider, every individual, every family member to review the detailed clinical coverage policy language when it is released. And please participate in the feedback process. At this time, I will turn the slide deck over to, I'm sorry, I think it's Latoya.
Okay. Do we have any questions?
Latoya? I'm sorry.
Are there any questions that you guys want to answer?
Yes, if you can hear me, I'll read a few questions and provide some answers that were sent over in the Q&A.
Sounds good.
All right. Supervision requirements say between 10 to 20%, but we've noticed a sharp increase in treatment plans being denied if they are above 10%. Does the more than 10% need to be justified? The response to that is all aspects of a treatment plan, including observation and plan modification, should be justified by the clinical needs of the beneficiary. Our next question was, how will profound autism be treated if requiring titration plans? The response to that question is that RB BHT is not a habilitative service. For those individuals with substantial habilitative support needs, other services would be appropriate to support those needs. RB BHT interventions can be used to support paid and natural supports of habilitative and support services to adapt interventions consistent with the individual's autism related needs. And there was a question of the slides being available after the presentation. Yes, they will be available after the presentation. If you refer to the chat, there is a link where the presentation slide decks will be available. And there is a question regarding behavioral technicians and the 100, or excuse me, and the requirement for them to be nationally registered. And the response to that is behavioral technicians must cease rendering services if they do not obtain required certification within 120 calendar days from their date of hire. And another question, I would like clarification on the accepted tools to diagnose autism. CARS-2 is not included, and that is not an accepted tool for initial diagnosis. And another question regarding is there a grandfather period for those telehealth BCBAs who are currently licensed in North Carolina? And there is not a grandfather period, as this is a new statutory requirement. And thank you. That is all the questions currently.
Thank you. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our webinars page. For more information and resources, stay connected with DMHDD-SUS by attending our monthly side-by-side webinars and join our monthly mailing list. The links are included in the chat. This concludes our webinar for today. Thank you for attending.